Good afternoon, good morning, good evening, and welcome. My name is Judy Khanyola. I'm the Vice President of AFREhealth and moderating today alongside Professor Jean Nachega of Stellenbosch University. This is our monthly emergency Ebola webinar, a space where the people actually running the response tell us what's working. And right now, Bundibugyo virus is moving across DRC. And here's what makes today urgent. We know some of the information around the Bundibugyo Ebola strain. There is no licensed vaccine and no specific treatment. And when you have no vaccine, community engagement and risk communication aren't the soft edge of the response, they are the response. And that's why we are here today. 3 quick things, please. Stay muted. We are recording. And most importantly for us, drop your question in the chat from the very first minute. Don't wait for the end, please. As the questions come up in your mind, drop them in. Professor Nachega and I are watching it live, and we'll bring the best ones into our discussion. So let's begin. I will ask Professor Nachega to introduce our first panelist.
Thank you, Judy. So my name is Jean Nachega. I am a professor of infectious disease at Stellenbosch University in Cape Town, but also faculty at University of Pittsburgh and adjunct faculty at Johns Hopkins, where I did train. So we have a really terrific speaker, and we're very lucky to have our first speaker, who's going to be John Quattrochi, who is an epidemiologist and an associate professor of global health at Georgetown University in Washington, D.C. He has worked in DRC since 2014, so he's really a brother, a friend, and a colleague. First time I met him was in a plane, I think, from Kigali to Cyangugu. So it was just remarkable that he reconnected and reminded me that that meeting. He has collaborated with several universities in DRC, from University Catholic of Bukavu to the University Panzi Hospital, University of Lubumbashi, and others. His research focus is primary design and scaling of intervention to improve maternal and child health in low and middle income country. So he has really very hot data on Ebola from Bukavu. So you are privileged to be the first to kind of be exposed to this data. So back to you, John.
Thank you, Professor Nachega, for that very kind introduction. It's really a pleasure and an honor to be a part of this webinar. I applaud you all for organizing it. I think this is really important during this urgent epidemic. And as you said, this data is very hot, very fresh. In fact, we're still collecting data on this survey. We'll finish next week and hope to get something out as soon as possible. So yeah, what I'm going to present, and I will try to keep it to about 20 minutes, and I'm happy to be interrupted by other panelists at any point if you want clarification or just want to discuss something that comes up. But so this is a survey led by Peter van der Went at New York University, Abu Dhabi, on Ebola misinformation, trust, and preparedness in one particular neighborhood in Bukavu, which, if anybody's not familiar, it's a city of about 1 million people that has not yet been reached by the epidemic, but is quite nearby. And we've had this survey as also an interpretation of the results has had important contributions from Professor Nachega and from Martin Voers at Wageningen University. So to get right into it, here is this is the latest map from the CDC on the left here, showing which health zones have been affected by Ebola in Congo. So those darker red health zones have been affected. And you can see down, Bukavu is down in South Kivu next to Rwanda. There's a health zone right next to Bukavu, Miti Maresa, that has had 2 cases, but there have not been any cases in Bukavu yet, but it's not far. So what we're interested in with this survey is we wanted to learn what's the sort of baseline level of trust, misinformation, preparedness before an epidemic arrives in a city, because unfortunately it's quite possible that Ebola will arrive in Bukavu, in Goma, in Kampala, in Kigali, in Bujumbura. These are the cities near the epidemic right now. Kisangani has already had a small number of cases. And then on the right here, where it says Zone Kadutu, there's a wonderful real-time dashboard that has been put together by the National Institute for Public Health in Congo, and the website's down there in the lower right, that shows this is the health zone where we did our survey, total population of 267,000 people, and they've integrated data from mobile phone companies showing how many people are coming into this area and leaving from areas affected by Ebola. So it's trying to put some more numbers on how at risk each health zone is in DRC of Ebola coming in. Okay. So what we wanted to do in this survey is measure 4 things: how much knowledge and information people had about Ebola, about how it's transmitted, what people can do to protect themselves. Then trust, how much trust people had in health workers, different levels of government, NGOs, and other actors that might be involved in the response. We asked people, thirdly, about material and economic preparedness. So can they obtain gloves, disinfectant? Could they realistically comply with a 21-day isolation without collapsing financially? And then fourth, we're going to look at predictors of these other 3 domains to see if there are particular groups that are vulnerable. And this survey it's in one neighborhood within Bukavu. It's a large neighborhood, but we enumerated 26,000 people across 10,000 households. And then so far we've talked to about 3,400 people. Women are oversampled in this, as are displaced people. So there is a caveat that so far I'm going to show you unweighted results. So once we weight them to be representative of the neighborhood, they might change a little bit, but because we already have over 3,000 respondents, we don't think they'll change much. And this is one neighborhood in Bukavu, so it may not represent all of the city, but it's the best we have at the moment. So our sample, who's in our sample? As I said, we oversampled women. It's 90% women. There's a range of adults. About half of the sample has a secondary education or higher. 25% employment. That's probably a reflection of it being 90% women. 74% own a mobile home. 26% were displaced. That's it says recently, but it's really in the last 5 to 10 years. And I'll just move on from there. So first set of results. We asked about knowledge and belief in misinformation. So the good news at the top, I would say 86% of the respondents have heard of Ebola, although you could say it's troubling that 14% have not. If we look within the 86% of people who have heard of Ebola, 82% believe that Ebola is a real disease. 91% believe that Ebola can kill people. 92% believe that Ebola is contagious. Then we asked about some common misinformed beliefs. So 35% of people believe that Ebola was fabricated for financial gain. If we include people who say they don't know if it's fabricated for financial gain, that number goes up to 53%. Similarly, 33% believe that Ebola was fabricated to destabilize the region, and 7% believe that it was caused by witchcraft. So there is some misinformation that needs to be addressed in the response. Then at the bottom here, we asked people about their knowledge of transmission routes, symptoms, protective actions, and people could name about a third of the total list. And I think I have some more detail on that. So Ebola transmission routes, 55% of people correctly named body fluids as a transmission route of Ebola. Contaminated objects, body of someone who died from Ebola, blood, those are all similarly reported. 14 to 17% of people thought that Ebola could be transmitted by water or air. So that would be something to address in the response, or insects down here at 8%. What symptoms do people associate with Ebola? The most common is fever. That strikes me as helpful, followed by headache, unexplained bleeding. These are all under 50%, so I think there's room for improvement in terms of educating people about what symptoms are associated with Ebola. And then as far as actions to protect against Ebola, 83% of respondents named washing hands with soap and water as an action that can be taken to protect against Ebola. Then that's by far the most common response. Avoiding contact with symptomatic people is down at 45%. Cleaning, disinfecting surfaces at home at 39%. Avoiding handling bodies of the dead at 35%, and so on. So there could be, it could be useful to put some more emphasis on avoiding handling bodies of the dead, avoiding large gatherings and crowds in particular, I would say. I would take it as a good sign that very few people mentioned wearing amulets, drinking hot tea or salt water, eating garlic or special herbs. Now we move on to our second dimension, which is asking about trust. So we've covered knowledge. We're looking at how much people trust different actors in the city, in the region. So first, we just asked about trust in general. How much do you trust fellow household members, international NGOs, neighbors, the national government, people of a different ethnicity, local leaders, displaced people, and current city authorities? And then I'm showing you the percentage of people who reported a lot of trust or completely trust, so quite high levels of trust. Not surprisingly, I would say, fellow household members are the most trusted. I was surprised that this is still only at 53% rather than higher, but I think it's a useful benchmark. The next most trusted group was international NGOs at 10%, quite a bit less trusted than fellow household members. That's followed by neighbors at about 6%, then the national government at 5%, people of a different ethnicity 4%, local leaders 4%, displaced people 3%, and current city authorities 2%. So that's quite a striking difference even between international NGOs and current city authorities. Bukavu, of course, is under rebel occupation currently, so that may explain why those levels of trust are so low, and that's going to be, I think, a major challenge for any response in the city. Our second trust question was about trust, particularly in people or groups providing information about Ebola. And there, positively, I think, health and hospital staff are the most trusted. Again, this is the percentage of people reporting high levels of trust. However, it's only 33% of respondents that reported a high level of trust in health center or hospital staff. I was surprised that it then drops down to 15% for community health workers. And then it's a bit lower for Ministry of Health, international NGOs, television journalists, national government, radio journalists, and then even lower for local leaders, current city authorities, and traditional healers. I think it's probably a positive sign that traditional healers are not trusted for Ebola information. Again, keeping in mind that this is an urban setting, I don't know, we might see different responses in rural areas. But I think this is a positive for the response that health center and hospital staff are the most trusted group, but there's still work to be done. About 70% of the population does not feel a lot of trust or more in health center or hospital staff. We asked specifically about trust in advice sent to people's phones. thinking that this might be a helpful way to disseminate information. Now, we did not specify who was sending the information. So this was just a general question. How much would you trust advice about Ebola sent to your phone? 30% of people about said that they would not trust it at all. 35% trust a little. And only about 18.9% would trust it at least somewhat or more. So this seems to be a limited channel for disseminating information, but perhaps if we specified the sender, that would change these answers. Now, our third dimension was readiness. The top rows here are about material readiness. What percent of, we asked people, do you have soap for hand washing or could you obtain it if it was needed? 74% of respondents said yes. We asked about disinfectant. There, only 13% of respondents said that they could obtain it if needed. And only 3% said that they could obtain plastic, rubber, or latex gloves. So those materials may need to be provided publicly, and it may be time now to start pre-positioning. Looking then at behavior, intentions, and economic capacity. Only about 11 or 12% of people said that they had avoided physical contact in the past 4 weeks or avoided public gatherings in the past 4 weeks. That's perhaps understandable given that there have not been any cases of Ebola in Bukavu yet. Promisingly, 89% of respondents said that they would seek care if they were symptomatic for Ebola. The last row here, 51% of respondents said that they could not cope with a 21-day work stoppage. We chose 21 days because that's the typical quarantine or isolation period. So that would be quite challenging for half of the population. All right. My last set of figures here are a little bit complicated. I'm showing now correlations between particular characteristics of respondents and certain outcomes. Let me check the Q&A for a second. Aha. Okay, I see the question about social groups and misinformation. Perfect. So let me take one moment to explain this graph for a second. We have two outcomes here. In the blue or green, bluish green, we have whether or not somebody has heard of Ebola. And then in the red, we have whether or not someone believed in one of those pieces of misinformation. So female is the first covariate here, first characteristic. If the bar is bolded, that means it's statistically significant. If it's grayed out, that means it's not statistically significant. So female respondents were more likely to have heard of Ebola than male respondents. And there's no difference between female and male respondents in terms of belief in misinformation. That's what we're learning from this first row here. The second two rows are age groups relative to the youngest age group, which is 18 to 24-year-olds. So people who are older than 24 are less likely to have heard of Ebola. People who are 55 to 90 are less likely to believe in misinformation. So I thought that was interesting that these older folks are both less likely to have heard of Ebola and less likely to believe in misinformation. Now, the employed are more likely to have heard of Ebola. I'll skip down to our next statistically significant results. People with at least primary or some secondary education or secondary or more are more likely to have heard of Ebola, and secondary or more are much less likely to believe in misinformation. So any kind of addressing of misinformation may need to be targeted to less educated groups. People who own a phone are more likely to have heard of Ebola. People who have recently reported a health problem. People who have signs of depression are more likely to believe in misinformation. That may be a difficult group to target, but it could be worthwhile. And then lastly, household size above the median, larger households more likely to have heard of Ebola and less likely to be misinformed. I'm going to show you two more figures like this. This figure, now the outcomes are, does the group express high trust in health staff meaning hospital staff or health facility staff? And do they trust advice sent by phone? Starting with phone advice, it looks like women and folks who are employed are less likely to believe advice sent by phone, but people who own a phone are more likely to believe that advice. Maybe they're more used to using a phone. And then in terms of trusting health staff, the highest educated group is more likely to trust health staff. Displaced people are less likely to trust health staff, and wealthier households with assets above the median are more likely to trust health staff. So displaced folks may need particular outreach for building trust in health workers and the health system. Now, preparedness, we have 4 outcomes. This figure gets a little more complicated. We have soap, disinfectant, gloves, and whether or not somebody said that they cannot stop work for 21 days. People who are employed were the most likely to say that they cannot stop work for 21 days. They're also the most likely to have access to disinfectant and gloves. People who are married would also have problems stopping work for 21 days. People who have some education relative to none. So any of these 3 higher education categories, those people are more likely to have soap. The most educated folks reported that they would not have problems stopping work for 21 days. And then let me skip down to, again, the wealthier households, assets above the median. They are more likely to have soap, more likely to have disinfectant. So not surprising, perhaps, that those households would be more prepared. Okay. So to summarize these findings from this predictive analysis, we find that the groups that may need targeted efforts, if targeting is possible, and it may not be worthwhile, but if it is, the less educated residents of this neighborhood tend to have higher rates of belief in misinformation, less knowledge about Ebola transmission, worse access to soap, disinfectant, and gloves. Displaced folks had lower trust in the health center and less access to soap and disinfectant. People with depressive symptoms, greater belief in misinformation, and slightly worse access to soap, disinfectant, and gloves. People who are employed, married, or household heads, they materially were better off, but they reported that they would have greater difficulty if there was a 21-day work stoppage, 21-day isolation period. And then lastly, older adults were less likely to have heard of Ebola, but also less likely to be misinformed. Okay, so just to, again, put some caveats on this, we are asking, these are all self-reports. So in terms of care seeking or hygiene, there may be some social desirability bias, some inclination for people to report more than is true. These results come from one neighborhood in Bukavu. It remains to be seen whether that is representative of the rest of Bukavu, other cities, or rural areas. These are interim unweighted estimates, which means we have more women in our sample than are in the city proportionally. So we will need to adjust for that in our final analysis, which we hope will be done next week. And then lastly, this is cross-sectional. So these associations I'm talking about between, say, less educated people and knowledge or misinformation, that may not be a causal relationship. Nonetheless, it may be useful for targeting. So to summarize and put forward some questions, some open questions, and I'm curious if people would draw different kind of key points from this. But what stuck out to me, number one, is that misinformation is widely believed, but care-seeking intentions are high. So I think there's potential, a lot of potential for the health system to serve people, for people to seek care and build trust initially. Similarly, number two here, hospital and health facility staff are the most trusted. can they be the ones to lead communication about the outbreak is an open question. And another open question, why are community health workers so much less trusted than hospital and health facility staff, at least in this setting? Number three, we saw that local leaders and city authorities are among the least trusted. That may be quite challenging for the response to adapt to. Can the response work around these authorities, or is there a way to build trust quickly? That has been challenging in other settings, but perhaps there's a way. And then the last key point I would highlight, most households cannot acquire disinfectant and gloves. So perhaps it is time now to pre-position stockpiles before Ebola arrives. Thank you very much for this opportunity to present, and I am happy to take questions or hear thoughts.
Yeah, thank you so much, John. That was terrific. We're going to have a general Q&A session. But if anyone has some very quick burning question, one or two, John can definitely take it. Yeah, I have write down mine, but I can hold until the general sessions. Any quick burning question from anyone? You can just jump on a mic and introduce yourself and ask your question. Or Judy, there was anything in the chat?
Their hands up, Jean.
Okay.
I see some hands up.
I have difficult to see it from here.
Wolfgang Preiser.
Yes. Yeah, go ahead. Introduce yourself, please.
Thank you very much, Wolfgang Preiser from Stellenbosch University in South Africa. Thank you very much for this insightful presentation, really extremely important topic. I wonder whether you also got some sense of how in the amongst the many challenges that the Eastern DRC face, especially in terms, I mean, including in terms of infectious diseases like cholera, measles, Mpox, and others, how relative to these, how high Ebola ranks amongst the population's concerns. I think that would be really interesting because they may have, be facing cholera and that may be upmost on their mind, and maybe Ebola seems relatively remote in comparison. Thank you very much.
Yes, absolutely. Sorry, Professor Nachega, did you want to respond?
No, go ahead. Go ahead.
Yeah, and there's research. I mean, I think this is an excellent point. Even beyond other infectious diseases, there's research from the 2018-2020 epidemic in Congo that in some areas, insecurity, threats from violence are a much higher concern for people than Ebola. Food can often be as great a concern as Ebola. So this is, yeah, absolutely a situation where people are facing multiple risks and trying to make the right decisions and make the right trade-offs. We didn't ask specifically about the relative importance of these threats, though.
Jean, I have 3 questions in the chat.
Yeah.
From Adane Tesaga, he asks, which social and educational groups were believed to be to have Ebola outbreak for financial gain? You mentioned that in your presentation, that communities believe that Ebola was fabricated for financial gain. Were you able to discern which social and educational groups?
Yes. So the best I can do right now, we could look at that specifically. I'll make a note. But right now, in this figure, we've combined these red lines for misinformed. That's combining fabricated for financial gain, fabricated to destabilize the region, and caused by witchcraft. So somebody who believed any of those would be counted as misinformed in this figure. And you can see that it's people with depressive symptoms, perhaps surprisingly, that are more likely to be misinformed than these other groups. But similarly, people who are the most educated are the least likely to be misinformed. So folks with lower levels of education have slightly higher beliefs in this.
And
And
just quickly
similarly, the
moving
oldest
on.
age group. Sorry.
Yeah, we have two more quick questions, and then I'll hand over to Jean to introduce our next speaker. What are the biggest challenges in controlling the current Ebola outbreak from your study, or from what you've presented to us? And what are the key actions that frontline health workers should prioritize based on these findings? That's a question from Bashir Mohammed. To you, John.
Sure, and Professor Nachega would be much better placed to answer this question than I would. But just, keeping in mind, we're in a city where there's been no cases so far. Um, it's this, we're finding this mixed result where these care-seeking intentions are high. Hospital and health facility staff are the most trusted. I see those as positives, but overall trust levels are quite low. And there is this misinformation circulating around. So I would say if things don't go well at the very beginning, it could become very difficult very quickly. That's sort of my overall interpretation of this situation.
And then again, he follows on to say, so countries who have no way or any case of Ebola at the moment, how can they prevent and create effective protection and control systems?
Yeah, this is related to the broader challenge of strengthening health systems generally. And luckily we've been doing that for a long time. We know what can be done. Each country is at a different place in that trajectory, but we need to, I think strengthening your health system generally will help with Ebola. But prepositioning stockpiles of things like disinfectant and gloves, and soap and hygiene kits might also be helpful now.
And the one last question is, why is this contrast between health facility staff and hospitals and most trusted versus community health worker as less trusted? Why did you get an answer to that?
No, that's a question that is forefront in my mind as well. If I had to guess, I would, health workers, hospital staff tend to have more training, to be more educated, to have more experience. Perhaps that's why they're more trusted, but that's just a theory at this point.
Thank you very much, John. As you can see, you've elicited a lot of thinking. And so please stay on because I know more questions will come through. But over to you, Jean, to introduce our next speaker. Thank you very much, John. It was lovely listening to you.
Thank you. The data are so rich. And so luckily, we have a social behavioral scientist with us from DRC, Dr. Esaie Kindombe. He just got his Ph.D. from University of Kinshasa. He's a current D43 postdoctoral fellow in our D43 program that we have with Professor Muyembe at INRB. And D43 that AFREhealth contributed for INRB to be successful. So we are very proud of INRB securing that D43, which is building capacity. So I see Professor Nelson Sewankambo on the call, our president. So really, this is in terms of AFREhealth contribution to capacity building, and we have here the product really of that capacity building on the forefront. He's gonna connect from Bunia, Ituri, and hopefully some of the key really question that this survey is raising. For example, how to build trust. Trust has been one of the key issue. Health facility being put on fire at Rampala site because the community just don't trust authority, international partner, and so on. And somewhat they've been, at the beginning at least, they were kind of not involved, really integrated in the response. So I think those type of question, maybe Esaie will have some preliminary insight. So Esaie, are you able to share or should I share for you?
You can share for me. You can share for me.
Because I have your slides, so let me try to share for you. Just bear with me. So this is just a slide I added. Maybe you can comment on where you are now, which in Bunia, just the setting. So also something, is I going to speak in French? There is, understood, there is a translation. Is that correct, Winfred?
OK.
Yes.
Yeah, so vous pouvez parler en français, Esaie.
OK. Merci beaucoup, professeur, pour m'avoir accordé la parole et bonjour tout le monde. Je voulais vous présenter aujourd'hui à partir de Bunia, là où je suis. Et ça, c'est la carte, la cartographie une carte de la RDC. Vous pouvez, oui, slide. Alors, le contexte par lequel nous travaillons ici, dans la province de l'Ituri. L'Ituri est une région vraiment fragile et marquée par des conflits armés. Il y a aussi les conflits non armés, mais c'est entre les différentes communautés. Et il y a aussi plusieurs déplacements de la population. Et deuxièmement, le contexte de l'épidémie de Bundibugyo dans la communauté avec des décès communautaires. Donc, jusqu'aujourd'hui, on continue à enregistrer des décès communautaires. Et il y a aussi la faible confiance envers les interventions biomédicales et plusieurs rumeurs et désinformations amplifient la peur et la résistance de la communauté. Slide. Alors, les difficultés actuelles de la réponse, nous avons la méfiance de la communauté vis-à-vis des équipes médicales. Nous avons la stigmatisation des survivants et des familles touchées par la maladie. Et nous avons aussi des rumeurs sur les essais cliniques et les traitements en cours. Et il y a une faible gouvernance participative et de transparence. Faible ou retard de la fréquentation des structures de soins par la communauté suite au discours faisant état de manque de médicaments et de vaccins pour cette souche d'Ebola. Slide. Alors, le défi actuel à relever dans le cadre de cette riposte, d'abord, il faut la restauration. Donc, il faut restaurer la confiance entre communauté et les institutions. Il faut assurer une communication claire, adaptée aux langues et cultures locales. Il faut intégrer le leader communautaire et religieux dans la riposte. Ils sont déjà là, mais il faut au fait il faut les intégrer, les ajouter encore, c'est très important. Et puis, il faut préparer les communautés à répondre aux futures épidémies. Donc, la communauté doit être vraiment préparée parce que ce que nous vivons aujourd'hui, même dans les différentes communautés, cela montre qu'à suffisance, la communauté n'a pas été préparée au début pour répondre à une éventuelle épidémie de cette envergure. Slide.
Sorry, let me interrupt,
Là,
please, Jean.
Oui, yes.
I just want to explain how to access the translation.
Okay.
Please, members, go to the bottom of your screen. You'll see the 3 dots which say more. And then you can click on the ball that says interpretation and then click English. And then you can hear what Esaie is saying in French. I'm very sorry for that delay for that. So just give 1 minute or so, Jean, and then 1 second, and then I hope everything is now okay. We've got the interpreter.
Okay. I did go at least a slide back so he can read.
Yes, please. Yes.
OK.
Attends d'abord qu'on vérifie si... Judy, could you check with you if some been able to connect to the right channel?
I hope all of you colleagues can correct to the right channel now, can connect, sorry, to the right channel. Participants, are you now okay? Let me see the chat. It's working. So please now you can continue. Merci beaucoup.
Oui, Esaie, peux-tu reprendre ces dias? Comment restaurer la confiance? Ça, c'est un des aspects importants de l'exposé de John. Comment restaurer la confiance? Quelles sont les stratégies? Je crois que ces dias donnent quelques approches. Pas exhaustives, mais quelques approches.
Merci. Alors, comme défi à relever, il faut restaurer la confiance entre communauté et institutions, assurer une communication claire, adaptée aux langues et cultures locales. Il faut intégrer le leader communautaire et religieux dans la riposte. Ils sont déjà là, mais il faut renforcer cela. Et puis, il faut préparer les communautés à répondre aux futures épidémies. Comme actuellement là, ça montre que les différentes communautés n'ont pas été préparées pour une épidémie de cette ampleur. Alors, les communautés sont surprises de l'ampleur de l'épidémie et ils n'arrivent pas vraiment à contrôler ou à respecter les instructions et à adhérer aux instructions de la riposte que la communauté, que les institutions médicales, les institutions donnent aux communautés. C'est très important. Alors, il faut vraiment un engagement communautaire prononcé, bien approfondi, pour l'adhésion sociale car l'adhésion sociale est un facteur clé du succès de la riposte. Les communautés doivent être partenaires, pas seulement de bénéficiaires. Et l'OMS insiste sur la transparence et l'implication locale de la communauté dans la gestion des urgences de santé publique. Et il faut une gouvernance participative. Donc, s'il y a une gouvernance participative, il y aura légitimité et efficacité des interventions. Slide. Et la communication des risques doit être très importante pour informer sans alarmer. C'est pour ça il faut des messages clairs et adaptés. Il ne faut pas s'alarmer devant la situation, mais il faut donner des messages clairs et adaptés. Il faut utiliser le radio local, les SMS, les réunions communautaires, multiplier les réunions communautaires pour vraiment utiliser la communication du risque. Il faut identifier et corriger rapidement des rumeurs. Parce que si on ne gère pas de rumeurs, ça va être vraiment un problème dans la communauté et l'épidémie va continuer à dans la communauté et puis ça va être difficile. Il faut garantir la confidentialité et le respect des participants ou des malades. C'est très, très important. Slide. Préparation aux épidémies. Donc, il faut renforcer les capacités locales. Donc, la formation, médiation, outils visuels. Il faut développer les mécanismes participatifs durables dans la communauté et créer un modèle transférable pour d'autres contextes fragiles en Afrique centrale. Et anticiper les crises futures par une gouvernance inclusive. Donc, là, il ne faut pas attendre d'être surpris par l'épidémie. Hein. Il ne faut pas que les épidémies puissent nous surprendre et qu'on commence à chercher comment anticiper les choses. Non, nous devons anticiper pour les futures épidémies. C'est très important. Slide. Alors, il faut problème que cela doit résoudre. Donc, ça va résoudre la méfiance et le remède, améliorer l'adhésion aux essais cliniques et interventions de santé publique, et ça doit protéger les équipes et les participants contre la stigmatisation. Ça doit favoriser une riposte plus rapide et plus efficace. Slide. Alors, impact attendu sur terrain, il y aura la confiance accrue entre communautés et les institutions. Il y aura la participation active des leaders locaux et même le survivant. Il y aura le renforcement des capacités locales en communication et gouvernance. Et il y aura la production des recommandations opérationnelles et scientifiques. Slide. Pour conclure, l'engagement communautaire et la gouvernance participative sont essentiels pour vaincre Ebola, surtout cette souche de Bundibugyo, parce que l'épidémie reste communautaire. Il faut vraiment un engagement communautaire accru et la gouvernance participative. Il faut la communication des risques. Donc, la communication des risques doit être transparente, adaptée et continue. La préparation aux épidémies repose sur des communautés informées et impliquées. Cette approche crée un modèle durable pour renforcer la résilience sanitaire en Afrique, surtout en Afrique centrale. Je vous remercie.
Thank you so much, Dr. Esaie Kindombe. That was really insightful from a social behavior scientist perspective, which actually gives some a lot of answer on some of the question, the survey from Dr. Quattrochi issue raised in his survey. So I'm gonna hand over to Judy Khanyola to introduce our next speaker. And this is a quite also interesting topic, which is going to also address some of the issue the survey is addressing, and also recommendation from Esaie in terms of learning, population learning using online system. Judy, back to you.
Thank you very much, Jean, and thank you to our previous speakers. You've been really very interesting. It's my honor to introduce Dr. Bekele Abera from Ethiopia, and he is going to take us through the education aspect of this work. He's going to talk to us about how to the missing piece. How do you get that knowledge into the thousands of people, as we've heard from the previous speakers? So over to you, Dr. Abera.
Hello, everyone. I hope my presentation is visible for all of you.
He's coming. Yes.
Link.
Great.
Thank you. So my name is Bakala Barra, and I'm a medical doctor and a lecturer from one of higher education, Ambo University in Ethiopia. And also I coordinate efforts and projects related to digital learning capacity building in Ethiopia. And we collaborate and work with ministry level and also universities and other healthcare stakeholders here in Ethiopia to build digital training capacity buildings. To just give you a glimpse of the background of our institution, just for an introduction, Lecturio is a digital medical education platform, which is leading and based in Germany and operates globally with a tailored teaching for different aspects, owning both pre-service and in-service contents in three domains, especially in information or knowledge buildings like videos, clinical cases, and articles, plus virtual clinical decision-making simulators and a procedure simulating platforms. And all of this following a precision teaching model, which is a tailored teaching for pace, time, interest of learner. And it is all about applying a precision medicine science to a precision teaching. And we use that model. And all of these are with high integrations, especially strong AI integrations for learners and faculty or educators. Especially for educators, it owns AI assistants and AI question generators or writers, AI strong lesson planner, and proctoring, as well as clinical decision-making simulator. And the same strong AI integrations are there for learners or students, like AI teaching personalizations that really tracks performances of students and reports that for monitoring for educators. And we do have collaboration, especially specific to this topic of interest, especially with International Federation for Emergency Medicine, which was built to help or to capacity building or training, the digital training for healthcare professionals for COVID-19 response, which showed a greatest improvement from pre-course to post-course training. So let me get back to my major presentation, which is specific to our today's topic, that is key success factors for effective e-learning in outbreak response. So in any kind of outbreak, an outbreak or any kind of emergency or disaster situation demands the workforce to get ready in any aspect of the responses. As you know, these four pillars of response for an emergency or an outbreak are important, like rapid recognition, infection prevention and control, standardized case management, and also coverage across every level of healthcare delivery units. And what really differentiates the impact being a contained outbreak and a catastrophic situation is all about workforce or health workforce readiness, not on every aspect of the outbreak duration, but on the first day or on day one, health workforce preparedness really matters on containing the outbreak or emergency or disaster situations for any kind of community. So across all pillars of emergency or disaster or outbreak or catastrophic situations, education really can be applied or can be used as a significant and very important pillar to respond to any kind of outbreak or emergency and disaster situations, especially in disaster readiness, continuous educations, digital trainings, or any kind of supportive education for healthcare workforce can help on early surveillance, surveying, and also resource allocation or facility preparedness, and also for emergency response. Again, education can really help in rapid triage workforces or in strict infection prevention and control compliances if the education method is a tailored one that is designed in a way it fits to high stress environments, and it enables such performances like strict IPC compliance or rapid triage workflows to be applied well. And also in first aid and trauma, again, disaster casualty care educations, and also ensuring frontline workers handle critical medical emergencies, biological threats, events, and also immediate life-saving interventions. All these pillars can be supported and significantly boosted if only supported with education, and education can really contribute well in these scenarios. So critical role of e-learning is not something to be ignored, and is not something that we save it for tomorrow, because our ability to train, equip, and mobilize our frontline healthcare workers must move even faster in such critical situations like in outbreak and also catastrophic disaster and also emergency situations. So for effective way of addressing training for any level of healthcare professionals, digital infrastructure, and also tailored track development is not something that we choose or not. It's not an optional, but it is a primary defense mechanism, since it can be used to boost any level of disaster or outbreak response. So how I can just let you know in 3 domains how the e-learning or digital learning can enhance an outbreak or disaster response. Especially, it can contribute in 1 domain to rapid protocol dissemination. Our protocols, guidelines, training manuals, treatment manuals to be distributed as fast as possible is very mandatory and crucial in outbreak response, and e-learning can support this. And for sharing standardized knowledge and updated knowledge, and then equipping the workforce with this standardized and updated knowledge is also a crucial domain where e-learning can contribute. And the third domain where an e-learning can contribute as a third very important pillar is offline resilience. Some platforms, especially ours, and also this kind of e-learning platforms can enable functionalities where offline availability or downloaded materials can even help in internet or connection problem areas. So in 3 domains, e-learning can enhance an outbreak and disaster response. So the factors that determine or impact how this e-learning can support an outbreak response are based on whether it can be a tracked, tailored, or system integration. A tailored curriculum is very crucial. It has to be a learning model that fits an emergency situation or a disaster situation. And also it has to be a system that can be tracked and that reports performances and also their activities on platform. And also the e-learning mode have to be a flexible and a customizable platform where it can be integrated to any kind of LMS, especially to ministries, and in a way it can be branded to a specific country or region. So this models or pillars are something that determines whether our e-learning capacity and also our e-learning methods can be successful in responding to emergency or outbreak situations. Let me put some of our project examples where we assisted an outbreak or a disastrous situation in boosting health workforce training. For example, this one is an ADAP, which has got to train more than 50,000 healthcare professionals across Ukraine and Europe, which helped in training this amount of healthcare professionals so that they respond to disaster situation in any situations like war or disaster, in this specific case for an outbreak also. And through our platforms and apps and offline availabilities, our platform was used to train the significant number of healthcare professionals, which later helped in disaster response. And also, these are some of examples like videos, interactive simulators, and demonstration videos on how to respond to trauma and emergency situations. And this one also a comprehensive curriculum for first aid, basic emergency care, and advanced trauma life support. And the other one is for mental health for healthcare professionals, especially in mental health crisis. Some of examples showing a demonstration on how to respond disaster casualty care and a digital training. So an outbreak response academy network of our platform can be at any level of collaboration, like collaborations can be at ministry or government level to leadership, high leadership collaborations, and also strategic resource prioritization, and so on. And also collaboration can be at hospital admins, and can be at a primary care unit level, and also it can be at a community health workers level. Specific to our today's session, which is about Ebola virus outbreak, we have developed an important resources and the contents which can be used to train health workforce to get prepared for an Ebola virus outbreak. And this is an example where we deployed full training of Ebola virus prevention and measures in collaboration with Ethiopia's Ministry of Health, and it is already deployed to the country's CPD platform, where many health workforce are being enrolled and getting the training online. Our training on Ebola and M.P.H response is from standard platforms, and also are from one of the name here, under the introduction, and also some of presenters were mentioning is Professor Muyembe. Professor Muyembe is one of a significant figure and very significant researcher, Director General of INRB, and investigated the first Ebola outbreak in Congo in 1976, and he led research for the first Ph.D. improvement treatment for Ebola. And Professor Muyembe has been to our studio, and he was recorded to give an insight and the challenges related to an infectious disease, especially specific to Ebola and M.P.H. And we have full training contents which are designed for Africa tailored training, especially using such an important professionals across Africa. And in Ethiopia, one of example is here, and one of our training component of this Ebola virus response training is on community health workers. The first presenter, John, was mentioning there was a misbelief in community, especially in those uneducated, are more to be misinformed, more to be less aware, and later more to be negatively impacted by the disease. So the other one is the health workforce as well, especially community health work force are the most believed one by the community, as the John's initial presentation mentioned. So for the community health work force, especially, they are last type of health care delivery units. So they can easily communicate with the community and householders and so on risk communication and hazard communication. Just as to mention as an example, we do have a communication simulator on how to communicate a hazard or a risk for a community as well as for healthcare professionals, which is with a strong AI integration. In this model, we can bring this to support community health workers training and also a community awareness raising. And this is something I tried to mention. This is a simulation platform. It is an AI dialogue training with angry community members. This can be used for a community awareness or for a community training. Here also, this is one of the example on how we can communicate to a community member, especially who are angry with regard to the outbreak, because we are going to impact their day-to-day life. As you were mentioning, some of the prevention methods will impact the community interaction. So you have to communicate it humbly and also in a comprehensive method. And we do have this practice model on how to communicate angry community members. So I hope Dr. Nituli is in the audience, who is leading East Central and Southern Africa Health Community, and we can jointly help in the containment and also preparedness of an outbreak to the new Ebola outbreak. With this model, East ICSA or East Central Southern and the Central Southern Africa Health Community have regional convening authority and also proven multi-day on-site training model. And as lecturer, we do have also a globally deployed digital platform with expert authored video training, and especially our training content is for Ebola outbreak. So with this collaborations in building, and we are signing an MOU with ICSA to just collaborate in building health professionals awareness and knowledge on the new Ebola virus outbreak. So each partner, especially both lecturer and the ICSA with over 50 years of regional health cooperation and established relationship with ministries in East Central and Southern Africa, and also with a proven multi-day on-site trainings and also deep infection prevention and outbreak response experience, adding our contribution or our resources from Ebola training with Africa-tailored training resources and a deployable academy, which is with a strong multiple high-end functionalities. We can bring together a strong training content or training platform which can boost Africa's healthcare professionals on getting prepared to the outbreak, new Ebola virus outbreak. And actually, we can't do it isolatedly in person, and also isolatedly online are not to be very effective or very successful, but we can combine them and make it a blended delivery model. By online, we can reach at speed, especially with knowledge boosting, with simulators, and also with continuous monitoring of which healthcare professional completed which component of the training and so on. Then ICSA helping with depth, hands-on practical sessions. Finally, we can achieve knowledge and a skill at national scale within weeks. And this can impact 100,000s of healthcare professionals across Africa. And so with deployable academy, actually we can monitor which healthcare professional is taking the training in percentage, and also how much part of the training they are completing. All these things are reportable and trackable. And with deployable academy and the national dashboards, we can achieve a well-trained and a well-equipped healthcare professionals when it comes to knowledge and also preparedness for the new Ebola virus outbreak. So just to start with how e-learning can effectively support or boost healthcare professionals' preparedness for an outbreak or for disasters that can be anticipated from this new outbreak, we can just start initially with consultation by identifying priority regions with ministries and also borders, districts, and central hospitals. And then we can configure it with a country branded or country tailored academy. And that can actually stood up in week and in short period of time. And then we can launch this for just first quarter live within days or within a few weeks. Then a blended online and on-site delivery can begin with few weeks. And then later we can work on how to sustain this with refresher simulations and drill cycles. And this is what we can put into this webinar for any kind of collaboration to boost preparedness of your healthcare professionals. We are ready to support at any level of collaboration. Thank you so much.
Thank you so much, Dr. Bekele Abera. I was a bit slow in giving him his proper introduction. He's an MD specializing in public health and currently serves as a country director for Lecturio, as you can see in his presentation. And he's also a clinical lecturer at Ambo University in Ethiopia. And his background includes extensive experience in project coordination focused on digital, medical, and nursing education, as well as hands-on clinical teaching. And we are really grateful to you, Dr. Bekele Abera, for sharing with us the great work you're doing, particularly related to the response in pandemics and Ebola. That is the focus of today's webinar. So Jean, I want to hand over to you. You had some questions for our panelists. There you have it. Perhaps we can go there. We still have a few more minutes and we can take some questions from our three esteemed presenters this afternoon.
Yeah, thank you so much, Judy. So these were very rich talks. I'm going to start with John briefly before we jump to the audience. So those are cross-cutting questions for John and for Esaie. John, from what Esaie just elaborated on, do you see how you can tell us some of the recommendations for this work in terms of addressing trust? Because this seems to be an important issue. And the second point is obviously they're going to be more data coming from Bunia in terms of this knowledge, attitude, perception. But are you planning on other region or do some longitudinal follow-up after some intervention?
Thanks for the question, Prof. Nachega. I think what we know about trust, I'm still digesting Esaie's presentation, but I think trust takes a long time to build, but we can lose it very quickly. So maybe for epidemic response, the right framework is how do we protect what little trust or whatever trust we have, whether it's a little or a lot. And I think the points. What I find interesting about our results is we often say it's important to work with local leaders or local representatives, but we're seeing this difference between health workers in the hospitals who are local, community health workers who are local, and then local leaders or city authorities who are also local. And there's 3 different levels of trust, it seems, in those groups, even though they're all local. So I guess we need to always adapt to context. And at least in the context of Bukavu, it seems like it's the hospitals and formal facilities that should really lead the way. Your second question about, we absolutely plan on following up with this population. And if we can fundraise adequately for interventions that might help, we would love to do that. We're working on that now. I think if we expand to other areas, maybe it would be through mobile phone surveys, and that's partly why we were asking those questions, in addition to their utility and the response itself.
Thank you. Any question from the audience? You can just jump in, present yourself briefly, and ask your question. I would like maybe to pinpoint Donald Skinner, another social behavior expert. Donald, do you have any general comment or question? Just to... Please mute yourself if you're not speaking. I'm not sure if Donald is still there.
We have Mineze Jean.
Yes, yeah, Mineze. Go ahead.
Not sure if he's on. Mineze, yeah, go ahead, yeah.
Yeah, I'm sorry, I'm in a noisy place, but I'll try to be brief. So my question is, I was asking to Dr. Esaie to know how do they work and ensure to build the trust between communities and institutions? And the second one was to know whether they do use interpreters or translators to reach out to community members, and what is the place of those, if they do use translators, and what is the place of those translators in building trust within the community? And I was asking, I think that one was already answered too, to know why was the contrast between, health facility staff or hospitals, being most trusted, whereas we know that community health workers are among communities. Why don't the community members trust those that are among them versus hospitals, and where they seem to be a bit far, not very close to community? So I just wanted to know, why is that contrast found out? Anyway, if there is any answer even by Dr. Esaie, it will be okay. Thank you.
Either John or Esaie can...
Merci.
Oui.
Merci pour la parole et merci pour des questions. Pour votre première préoccupation en rapport à pourquoi il n'y a pas la confiance entre le leader locaux et les institutions, si je ne me trompe pas, c'était ça votre première préoccupation. En fait, il y a plusieurs problèmes qui sont autour de la confiance. D'abord, si les gens viennent à l'hôpital pour prendre les soins, mais il y a plusieurs décès, il n'y a pas une solution. là, il y aura plus la confiance. Quand il y a beaucoup de décès, les gens vont chercher d'autres solutions palliatives. Ils doivent aller chercher ailleurs parce qu'ils pensent que non, voilà, à l'hôpital là-bas, il n'y a rien. Donc, il y a un complot là-bas. Si nous partons là-bas, c'est pour nous faire tuer. Alors, maintenant, ce, ce manque de la solution, je peux dire, adéquate, ça provoque au fait la communauté n'a pas vraiment beaucoup de confiance envers l'autorité. Et puis il y a d'autres théories des complots. Si nous partons là-bas, on va nous exterminer, on va nous tuer. Il y a des choses qui se passent là-bas. On ne comprend pas, on mutile il y a mutilation des organes humains, tout ça. Il y a beaucoup de choses autour de ça. Et puis, il y a beaucoup de rumeurs qui circulent dans la communauté autour des activités qui se passent, par exemple, dans les CT, devant les autorités, tout ça. Et tous ces problèmes-là font en sorte qu'il n'y ait pas la confiance entre les autorités et la population et les organes ou bien et les institutions sanitaires. Mais il y a plusieurs problèmes vraiment. Les problèmes sont tellement complexes, raison pour laquelle il faut vraiment rétablir cette confiance. Alors, pour établir la confiance, ce n'est pas aussi facile dans un clé d'œil. C'est vraiment un travail de longue haleine. Il faut vraiment les équipes travaillent vraiment dans la communauté avec les différentes personnalités, les responsables locaux pour expliquer et mettre en place les approches, ce que moi j'appelle les approches par village. C'est-à-dire rester en contact permanent avec les différentes communautés, les expliquer en permanence, les faire comprendre les problèmes, le risque, le danger, pour qu'ils puissent prendre conscience et puis rétablir la confiance entre les autorités et entre la communauté et les autorités. Donc, il faut rétablir cette confiance-là entre la communauté et les structures de soins. Alors, si nous utilisons des traducteurs, surtout nous utilisons le leader qui comprenne un peu les choses et les leaders à leur tour doivent expliquer aux différentes communautés dans des langues locales, passables, faciles pour une meilleure compréhension. Donc, il y a plusieurs langues locales. Nous travaillons avec des leaders qui comprennent des choses et les leaders, à leur tour, doivent expliquer avec des mots clairs à la communauté pour que la communauté puisse avoir une meilleure compréhension des choses. Je pense que je ne sais pas s'il y a une autre préoccupation que je n'ai pas répondu.
Bon, c'est un bon résumé, merci. Another question? Just jump in, introduce briefly yourself.
We have Dr. Wisbom. Stefan, are you able to say something? And also Dr. Skinner.
I had asked a question earlier, Judy. Thank you. This is Stefan Wisbauer, which was just a question to John in terms of what surprised him the most. I don't know if that's what you're referring to, Judy.
Yes, absolutely. Plus the issue of the training, you can put them all together.
Yes. So, so on the training side, and what was the specific question, please?
I think you were responding to what Abera has presented on the lecturio. Perhaps you can elaborate a little bit what you've posted on the chat.
Yeah, I would say so. Yeah, I posted to John actually. So I think it would be interesting to leverage these survey insights into concrete conversational training, for example. You know, what Michaela showed is like an AI conversation training, which obviously becomes a very important conversation if there's a risk of attack or risk of violence to the health worker and so on. So for those trainings to be really optimally reflecting the local concerns can help improve their effectiveness, you know. And And also just one point that I found quite striking is if 50% of the people are concerned about surviving an isolation period financially, they may also keep them from, despite good and declared intentions, to actually seek care, right? And it could also affect the desire of a partner, for example, of the breadwinner of a family who's infected, to really kind of, insist on access and so on, So being aware of these aspects can then help brief an AI dialogue training by making the configuration aware that financial concerns might also be a motivation, not just concern for the personal well-being of the isolated patient, but also concerns for the well-being and survival of the family, and sort of proactively asking about those things and mentioning that how that can be distressing can enhance communication training. And also it might be interesting to think through how one can make the concrete insights that are local and very relevant, make them flow into optimized training flows, whether that be AI dialogue or video trainings and so on. And speed, I think, is another key part there. I think part of the reason we're deployed in Ethiopia at the moment there is, I remember being at the World Health Assembly in Geneva when this whole news broke, and on that very Sunday, while I was in Geneva, we were coordinating updates to make sure we have something ready. We believe strongly in video formats, especially for health workers. Often dense PDF reading material is not very suitable for them. And so therefore rapidly creating kind of suitable targeted videos and then updating them rapidly is something that we believe can make a big contribution. A final comment I'll make is just the deployment often of these things. The World Health Organization obviously publishes a lot of things on the Academy, and that's great. We're happy to work with them and incorporate those things into locally owned, locally controlled academies, such that the kind of local district or the specific hospital can combine WHO contents with our video contents, but also with their local, specific, facility-specific, etc., information, and really manage their learners, see the results of these, etc. While ideally agreeing to be part of sort of an academy network so that the district and the nation can have an overview of what's going on where. This whole feedback loop, I think, is a very important potential factor in optimizing the responses. Thank you.
Thank you very much, Stefan. Donald, are you able to unmute? And if not, then I have Simon.
There we go.
Good. Go ahead.
Okay, sorry. I had a question for John. The one thing that struck me in your presentation was incredibly low levels of trust for everybody. And even the own household was trusted by, I think only the own household was trusted by more than 50%. And I know you pointed optimistically to the health workers, but that trust was still at around 20%. Who do they trust? I know this is a rhetorical question to you because you did the surveys, but I think it would be important to find out where that trust does lie, if anywhere, because that would be the starting point. And the local leaders they're identifying as very low trust are not their leaders. Those are leaders appointed by somebody else. So we need to really go in with some more high-level participatory work to get beyond these barriers.
John?
Yeah, absolutely. I think it's a great point. It's a shortcoming of any of these questions about trust is we're not exactly sure how people interpret that word trust and what they think we mean by it. That's why I think it's informative to look at the relative levels of trust, like the fact that household members are so much more trusted than people in health facilities, and then in turn local leaders. But absolutely, we should be doing more participatory work to understand better how people are thinking through the trade-offs that they face. I mean, the fact that 90% of people in our survey say they would seek care if they had Ebola symptoms is partly why I'm maybe interpreting the 33% trust in healthcare facilities as high, because I think we have to see those as together. But yeah, there's no substitute for observing behavior directly also as a complement to these trust questions.
Thank you.
I'm conscious we are 1 minute to the top of our webinar. So I want to be respectful of people's times and bring it to a close. And I want to thank very much Professor Jean Nachega. Actually, it's his background work and behind the scenes work that has brought all of us together here this afternoon. And Jean, thank you so much. I want to thank our three excellent speakers, Esaie and Bekele and John, for really the great work you're doing and also the time you've spent to bring this to us. I've personally taken away a lot of information that is useful in my own day-to-day work in terms of the work we are doing in Africa to begin to respond and prepare for these pandemics that have now become part and parcel of our lives. And so without further ado, I want to say thank you very much to everybody. Thank you for joining us on this webinar this afternoon and wishing you all a good rest of your day or evening. Thank you very much.
Thank you very much.
Yeah.
Thank you.
Thank you.
Thank you.
Thank you so
all.
much. Have a good day.
Bye, everybody. Bye.